Okay, in this video, I'm talking about the key features you need to ask when you are dealing with the case of a chlamydia patient or a patient who has got multiple sexual partners. The scenario might vary depending on what is asked in the scenario, but when someone has multiple sexual partners, this is what you need to ask in the history. The key features are sexual history, if they have multiple partners, if they had unprotected sexual intercourse, if they had a new sexual partner, past history of STIs, and partner with STI symptoms. And usually, chlamydia is most often seen in women, and some women present with vaginal discharge, intermenstrual bleeding, and pelvic pain. Then you need to ask about the contraceptive use, past medical history, which is any previous STIs, pelvic inflammatory disease. And the other thing I ask is if the partner has any symptoms, because sometimes this patient, the female patient, might have no symptoms at all. So these are the things you need to ask if they're sexually active, if they're risk of infection, like sex under influence of alcohol or drugs, then problems of discharge, dysuria, bleeding. Coming to the examination findings, you always rule out about general examination, then you do the female genital examination. This is the key where you look for cervical motion tenderness, mucopurulent cervical discharge, erythema or friability of cervix, and any lower abdominal tenderness if pelvic inflammatory disease is present. Male patients also present with chlamydia. In my practice, it is usually referred by the partner. The partner will tell the male saying, "Hey, look, I had chlamydia, you should go and get it checked." And sometimes when you take history, they will have urethral discharge and redness. Then rectal examination only if relevant. I usually do that only in homosexual individuals. Otherwise, I don't do that. Main investigations, the key will be to rule out differentials. The first, catch urine. This is very, very important, and this is what I do usually, and it's easy to do. So this is how you explain to the patient, hey, you get up first thing in the morning, the first bit of the urine should go into the cup. This is what I tell them, because that's where you can find the chlamydia and gonorrhea when you do a urine sample. Then vaginal swab is good as well, but it's a bit uncomfortable. Easiest thing, I always do the urine test. Endocervical swab, because sometimes women go for discharge, and when we take swabs we send all these things. PCR testing, then blood tests. Sometimes if they are high risk patients, you need to rule out other STDs as well, like HIV, syphilis, hepatitis B, C, if they are sharing needles. To confirm diagnosis, you just need the nucleic acid amplification test on the urine, preferably, or swab. Then the other thing is you need to rule out pelvic inflammatory disease and other infections where this is not common, but you may send them for transvaginal ultrasound. Very rarely laparoscopy, you don't need to do that. Then coming to the differentials, you need to think about gonorrhea, trichomoniasis, bacterial vaginosis, yeast infections or vaginal thrush, pelvic inflammatory disease, urethritis, herpes simplex virus. All these will present more or less with similar symptoms. Then coming to the management plan, pharmacological, first line is you just give azithromycin 1 gram. It comes as 500 milligrams tablet. You just give 2 tablets once and that's it. Or you go for doxycycline 100 milligrams for 7 days. The other key things are you have to notify the partner and also tell the partner to be treated, or else these people will keep getting it. If you don't treat the partner, then the patient is recurrently getting the infection. So that's very, very important. In the advice, you need to talk about it. Then for partners is very, very important. Usually it's in the last 6 months, all the partners should be screened. Then abstinence from sexual activity until the treatment has completed, or 7 days. And I usually always tell that they have to use safe sex practices like using barrier contraception. There are no need for surgery, and usually I repeat the testing in 3 months. Then education on barrier contraception, and talk about regular STI screening, especially if they have new partners, and general vaccination. So I hope this is helpful. If you need more, just leave some comments below and let me know how you are liking this, and I will do more videos on how to approach the OSCE or clinical exam cases.